Hello, everyone. I'm Dr. Mariam, a general cardiologist, and today I want to review an ECG with you that shows early warning signs before an acute myocardial infarction. Unfortunately, I've noticed that these findings sometimes missed in the emergency setting, even though recognizing them in time can truly save lives. So, we have a 64-year-old male with a history of hypertension who is a heavy smoker and substance user, presenting to the emergency department with a mild burning sensation in the chest. So, here you can see the initial ECG. Let's take a quick review of the basic principles of ECG interpretation. For classic ECG interpretation, we first determine the rhythm. To confirm whether the rhythm is sinus or not, we need to answer 5 key questions. The first question is, does the ECG show P waves? As you can see, we have the P waves in all the leads. The second question, are the P waves uniform in morphology? Yes, as you can see, the P waves are indeed similar. The third question will be, are the P waves positive in lead 1, 2, and AVF? As you can see, all the P waves are positive. And the fourth question, is there one P wave before each QRS complex? Yes, for each QRS complex, we have one P wave right before it. And finally, the fifth question is that the heart rate should be between 60 and 100, meaning it should be neither too bradycardic nor too tachycardic. Continuing the ECG interpretation, the second question relates to the rate. Usually, we calculate it by dividing 300 by the number of large squares between two consecutive QRS complexes. Here, the answer is 75. The third question relates to the cardiac axis. Given that leads 1 and AVF are positive, the cardiac axis is normal. Other questions we should consider in our minds relate to the measurements of the P wave, QRS complex, PR interval, and ST segment, which are all normal in the ECG. However, a notable point in this tracing that I wanted to share with you is the presence of the tall T wave, which is abnormally high in this ECG. To be very precise, in this ECG, we can observe mild ST depression in leads 1, 2, V5, and V6. To support my point, this article from the JACC journal published this year discusses the significance of the hyperacute T wave and its specificity for myocardial infarction. It even states that if the necessary features are present, it may indicate reperfusion even in the absence of ST elevation. The characteristics of hyperacute T waves are shown on the left side of this figure. The duration should be more than 40 milliseconds. It should have a broad base, be symmetric, and its height relative to the simultaneous QRS should be greater than or equal to 2/3. Other criteria for hyperacute T waves are also defined and can be reviewed on the left side of the slide. One additional point, this article does not explicitly provide a numeric value for the T wave amplitude. However, the T wave should be considered tall relative to its simultaneous QRS complex, which is an important criterion. Let's review the patient's ECGs again. The top tracing is the initial ECG we discussed, recorded at 4:40 a.m., and the lower tracing was taken at 6 a.m. As you can see, ST elevations in the anterior territory have clearly progressed. There is also some ST elevation in the inferior territory in leads 2, 3, and AVF. The patient underwent angiography, and the culprit vessel, according to the ECG, was the LAD, which had a subtotal cut from the proximal segment. Although there were also significant stenosis in the LCX and RCA, the patient is ultimately considered a three-vessel disease case. As a take-home message, I want to summarize: please take hyperacute T waves seriously, even if your patient does not have significant symptoms. Hospitalize the patient, obtain serial ECGs, and start initial treatments. And also ask for cardio consult. As you know, when it comes to heart, every second counts. Thank you so much for your attention. I will see you in the next video. Bye.